This will be a little bit more basic science thanks to Dr. Walter. Once again, the conflict of interest, Mike Report, my own company, and I'm a professor at the University of Michigan. Start with real basic science. A body remains at rest or in motion at a constant speed in a straight line unless acted on by a force. That means that if you put a force on something, it's going to keep moving in a straight line. Here we see an object. Could be the beginning of making a total knee prosthesis that's spherical. You put a force on it, it's going to move in a straight line. And Newton says that thing is going to keep on going forever until something stops it. Kinematics is the branch of science that deals with such motion and doesn't have any consideration for the mass or the forces acting on it. So again, one of these objects with a force on it is going to keep moving forever unless it gets stopped. Stability has a number of definitions, but if you look at what in yellow there, it is resistance to displacement. That is something that would stop something that's moving. A kinematic experiment and a stability experiment are pretty much the same. For a kinematic experiment, you put in a force and you measure the displacement. You're interested in the motion. For a stability experiment, you put in a force, you measure the displacement, and you're interested in the lack of motion. Both of these are the same experiment. If you consider this sphere resting on this non-conforming surface, the coefficient of friction of the sphere resting on the surface, and when talking about total joints, we're talking about polished metal sitting on plastic, times the force of ligament tension, with the increased force from above, body weight and muscle force, is what is the resistance to anterior displacement of that object on the surface. If the resistance to movement is inadequate, the sphere slides. This is kinematics, it's motion, but it's also instability. Based on the coefficient of friction, the combined force on the object resting on the surface, that is the metal resting on the plastic, must be 10 times the posterior to anterior force to prevent slide. We repeat that. The force acting on a component sitting on plastic to resist a slide must be 10 times the force causing it to slide. And I contend it looks like ligaments are not stiff enough or strong enough to do that job alone. They need some other force to prevent motion. And this suggests it may not be possible to balance a knee so that you don't have abnormal kinematics with just the force in the ligament. The force in the ligament would have to require that ligament to be deformed enough that it would provide 10 times the force trying to force it. So if there was a 10 Newton force or a 10-pound force, that would mean 100 pounds of force in the ligament. And that amount of deformation of the ligament could be as much as 5 or 10 millimeters. You'd have to put that on in the operating room to prevent the force, and then it would have to never stretch or anything else happen until it got until the patient started using it. Stability through congruence, however, allows the knee joint to have guided motion. The ligaments, I think, are poorly positioned and neither stiff enough or strong enough to guide kinematics, and congruity is far more efficient at guiding kinematics. Laxity is what we measure, and when we say we're measuring stability, but in fact what we're measuring is the elasticity of that ligament. Has it actually allowed the sphere in this case, or the femoral component, to come out of the congruence? A force, as we saw in Dr. Walter's presentation, that forces that sphere back down again will center the sphere and maintain stability. Whereas with a prosthesis resting on a non-conforming surface, the force from above must come down, and the only way to stabilize that, once again, is through friction, and that friction, the force down, has to be 10 times greater than the force trying to displace it. So explain to you some studies here that we've done. We just presented this at the ABJS meeting. Ligament balancing is unnecessary and may be detrimental for patient satisfaction using a medial-pivot knee prosthesis. We looked at 445 knees. That was 161 patients, 218 knees that we were able to follow. The important thing here is that we had very good knee society scores, yet our laxity examination, in full extension on the medial side, the laxity was 4 to 5 millimeters in full extension, 5 to 8 lateral, but when we got to slight flexion, we got 7 millimeters and up to 11 millimeters laterally. Once again, the laxity is greater on the lateral side than the medial side, but 6 millimeters of laxity means that the femoral component would have come out of contact with the surface and therefore not have the frictional load to prevent anterior posterior stability. Yet we had satisfaction among the patients that was very high. I conclude that laxity is not correlated with the score, and the reason I believe that's true is because the stability in this case is coming from congruence, not from ligament tension. We've heard of flexion instability from the Mayo Clinic. These patients have, oops, that was supposed to be a bunch of videos right there. Let's see if those will run. And the answer to that is no, so okay. This is a patient who was demonstrating the findings that the Mayo Clinic showed with flexion instability. What they discovered was AP instability. They discovered it in flexion. They called it flexion instability, but what it is AP instability. And the AP instability comes from the fact that the implants they were using didn't have congruity, and they hadn't tightened the ligaments tight enough, and I actually think it's impossible to tighten the ligaments tight enough to prevent that anterior posterior stability. They found that their patients were improved by revision to a PS or a CTK prosthesis. We recently presented at the Knee Society anterior posterior instability in the early range of flexion, found with anterior knee pain and found with a posterior sag near extension. We put these patients in a brace, and if they felt better in a brace, we revised them to a medial pivot knee. And of these 45 patients, 45 of them thought they were improved by having the medial pivot knee placed. This extension instability and flexion instability are the same thing. It is anterior posterior instability of the knee, caused by the fact that the surface is not congruent and by the fact that it is all but impossible to tighten the ligaments tight enough to prevent that anterior posterior instability. What we did in our cases was to tighten the knee joint in extension by placing the femoral component slightly more distal so that we got some good tightness in the medial collateral ligament and lateral collateral ligament, and then allowed the ligaments to be looser in flexion so that we could have the good range of motion in flexion. So these results support the hypothesis we believe that revision to a medial pivot prosthesis improved patients' outcome for AP instability and anterior knee pain. And I think that what this shows is that normal components, or the components that we put in that are not congruent, have anterior knee pain and problems because of the fact they're unstable in the AP plane, and that's because it's not really possible to tighten the ligaments tight enough, so the only way they can provide stability is with muscle force, and the patients end up complaining of pain and dysfunction because of that. So kinematics depends on stability. Kinematics and stability are the same thing. With a medial pivot, laxity does not predict instability, and revision of an AP unstable total knee to the medial pivot improves stability and patient satisfaction. Thank you.